Hello, let's discuss this question. A 55-year-old man comes to the office due to progressive abdominal distension for the past 2 months. He reports that his abdomen has become so large that his cloth is no longer fit. Okay, temperature is 37.5 degrees C, blood pressure is 152 by 87 millimeter of mercury, pulse is 80 per minute, respirations are 18 per minute. The abdomen is grossly enlarged and non-tender, shifting dullness is present. Trace pitting edema is identified in bilateral lower extremities. Paracentesis reveal bloody ascitic fluid. Repeat paracentesis from another site yields similar bloody fluid. Which of the following is most likely responsible for the patient's presentation? So, as this patient, 55-year-old male patient, has progressive abdominal distension, plus there is bloody ascitic fluid and from the multiple paracentesis. So, the bloody ascitic fluid is most likely occur in the malignancy. Okay, so the bloody ascitic fluid on multiple paracentesis. Okay, bloody ascitic fluid, it is most likely malignancy. Okay, so this is the first option is hepatocellular carcinoma, so this is correct option. The other option, nephrotic syndrome, is not correct because it causes the ascites, but the ascitic fluid is straw colored, yellow straw colored. Okay, and the other thing is that there will be diffuse anasarca uh, in the nephrotic syndrome. While this portal vein, the C option portal vein thrombosis is also not right because in the portal venous vein thrombosis there is no ascites at all. While in the spontaneous bacterial peritonitis there will be fever, okay, and abdominal pain. Okay, fever and abdominal pain. So this option is also not right. While in the tuberculosis there will be ascites, but ascitic fluid is straw colored, plus there will be the symptoms like fever or night sweats, okay, which is absent in this patient. So the tuberculosis is not right also. So let's move to the explanation of this question. Okay, so as we just see that the patient has new onset ascites, okay, abdominal distension, shifting dullness, that it persistently bloody on multiple paracentesis. Bloody ascites is caused by red blood cell leaking into the intraperitoneal fluid. Ascites appears frankly bloody when the peritoneal red blood cell count is more than 50,000 millimeter cube. Most cases occur due to localized trauma from paracentesis. However, these bleeds usually resolve without intervention. But persistently bloody ascite found on the multiple paracentesis suggest underlying malignancy. Hepatocellular carcinoma is the most common malignancy to present with the bloody ascites due to tumor growth disrupting and eroding nearby red blood cells. Less frequently, peritoneal mets from the distant primary sites can cause bloody ascites. Therefore, patients with bloody ascites should undergo abdominal imaging, measurement of the alpha fetoprotein blood levels, which is elevated with the hepatocellular carcinoma, and cytologic analysis of the ascitic fluid to identify the primary tumor. Unless the patient is hemodynamically compromised, okay, no specific acute intervention is otherwise required for non-traumatic bloody ascites. In the rare case of hemodynamic compromise, angiography with embolization should be considered. The choice B, which is the nephrotic syndrome, okay, nephrotic syndrome, it is not right because nephrotic syndrome can result in ascites in association with diffuse anasarca. It typically it typically causes non-bloody straw yellow ascites, and most patients also have severe lower extremity edema. The patient's trace spitting edema may be related to ascites and underlying cirrhosis, for example, hypoalbuminemia, but is unlikely to reflect nephrotic syndrome. And the C option, which was the portal vein thrombosis. It is also not right because portal vein thrombosis does not commonly cause ascites because the obstruction occurs proximal to the hepatic sinusoids. Hepatic vein thrombosis, like in the Budd-Chiari syndrome, can cause ascites. However, it typically causes acute onset of non-bloody straw yellow colored ascites in association with fever and abdominal pain. While the option D, which is spontaneous bacterial peritonitis, it typically causes fever, abdominal pain, and altered mental status associated with cloudy or turbid ascitic fluid, not bloody. A formal diagnosis requires an increase in ascitic fluid polymorphonuclear cell more than or equal to 250 cells per mm cube. The choice B, the which is abdominal tuberculosis, it can lead to ascites, but the fluid is generally straw colored. Bloody ascites is rare. In addition, tuberculous ascites is typically associated with abdominal pain as well as fever and night sweats, reflecting tuberculosis activation. Okay, so the if the someone has persistently bloody ascites after multiple diagnostic paracentesis, it is concerning for underlying malignancy. Hepatocellular carcinoma is the common cause, although bloody ascites can also occur with peritoneal mets from the distant primary sites like ovaries and prostate. Cytologic analysis of the ascitic fluid can be helpful in identifying of the primary tumor. So that's about the hepatocellular carcinoma.